Sorry, don't share. Got it. And unshare for me because I need to share mine.
Unshare. Because he's sharing his own slides.
Yeah.
Yeah. Yeah, it's
Sorry.
okay.
Technical difficulties. All right, so good morning. So really the goal here was to really highlight the value of echo in evaluating these patients for percutaneous mitral intervention. And really the how do we know what kind of patients is really dependent on that imaging. And the reality is what we're trying to do with percutaneous intervention on a mitral valve at the current time is really emulating what Alfieri described on the surgical world, where if I were to show you with this laser pointer, here is a view of the mitral valve from a surgeon point of view, where the leaflets are the anterior leaflet and the posterior leaflet. You're really trying to bring together the leaflets or the part of the leaflet that are prolapsing or not working so that you create a two orifice valve where the orifices don't have much of a regurgitative area. And so this is done percutaneously. Obviously, the major advantages is it's well tolerated, low morbidity and mortality, and patients are home in 1 to 2 days compared to surgery. But it only fits in certain category of patients where we think surgery may be more risky or not surgical candidates. But having said that, this is still a large proportion of patients. So from a surgeon's point of view, the way we think of the mitral valve is really in those kinds of terms. And when we describe the mitral valve, we really think of, are the leaflets moving normally, but there's still regurgitation? So if you had a dilated annulus, for example, that's how it would look. In a type 2 defect, you would have a leaflet that has lots of motion, like a ruptured cord. And a type 3 leaflet, which is often what we see and are difficult to treat, is are the leaflets held down and not moving normally, but one relative to the other, there's a defect that's created that leads to regurgitation. So this is really how we think of mitral insufficiency and sort of the therapies that we have for it. The reality is most of the world thinks of mitral insufficiency into primary, where it's something that's wrong with the leaflet or the valve itself. So it's components of the valve, whether it's the chordae, the leaflet, the annulus, the papillary muscle, all of those things are primary mitral insufficiency. And generally, from a surgical point of view, tend to be the things that benefit from surgery the most, while secondary mitral insufficiency are due to nothing wrong with the valve itself. They're due to the chambers themselves, either the ventricle or the atrium. If they dilate or they stretch in one area or another, can lead to distortion of the valve that makes it leak. So fixing the valve doesn't necessarily fix the problem, obviously, in these patients. And these are the patients that, as it's come to be, have fit more into the category of patients that might be available for percutaneous options in terms of over surgery. But in reality, both whether primary or secondary, there are patients that clearly, and I don't want to go into details of this slide because we've done this before in terms of guidelines, but clearly there are evidence that these patients can benefit from transcatheter valve intervention, and there are category 2A indications for interventions in both of these, and hence why we're talking about this today, because we have evidence that these patients can benefit from this. And with this, I really want to ask Jennifer to join us. Whoops, I need to stop sharing. And since she can share and really tell us today her perspective on how to assess these patients.
Okay, and I need a laser pointer. Okay, you can hear me?
Yes.
Okay, great. So thank you very much, JF, for that kind introduction and for putting broader context for my presentation. And thanks everyone attending today. So the program began in March 14th, 2018. Here we are. We've done our first 2 cases. It was a long day. We are looking exhausted but happy. And in putting this presentation together, I had the chance to remember Dr. Lichmedial, who was instrumental in founding this program, and remembering what a great colleague he was and how much we miss him. I'd like to think that he would be proud of how we're continuing to advance structural heart care in New Brunswick. So since 2018, we have done 27 procedures. So we are a low volume program. What you see here, I've broken down our cases into primary and secondary mechanisms and kind of bucking national and international trends. We've done more secondary than primary cases. So the outline of this presentation, I'm going to briefly talk about patient screening, and then I'll take you on a tour, a whirlwind tour of procedural echocardiography for the MitraClip procedure. Now, I have no disclosures, but I will use proprietary terms for the clip device by Abbott. And I will make some references to specific echo modalities from Philips. So patient screening, by the time the patients reach the operating room, they've already been assessed by the heart team. They're on maximal medical therapy. They have moderate to severe symptomatic MR. Our structural heart team is composed of heart failure cardiology, interventional cardiology, cardiac surgery, anesthesia, and we have contribution from our electrophysiology team as well. Each patient would have had a screening transesophageal echo, and it would be reviewed by an Abbott clinical specialist. So basics for screening echo, we want to make sure that there's no left atrial appendage clot, which would preclude doing the procedure, and want to rule out important intraatrial septal pathology. We also want to make sure there's adequate septal height for clip delivery, and I'll show you that measurement actually during my review of the procedure. Next, and very, very important, is to characterize mitral mitral regurgitation severity and mechanism. We also require a view and measurement of the mitral valve area, and there we would be looking for features that could preclude successful clipping. So I think most people are familiar with basic transesophageal echo views. So I'm only going to highlight a few that are particularly important. So the mid-esophageal bicom view, and in addition to the long axis view, these views provide the roadmap to the procedure. Now, the reason why the bicommissural view is so important is because it allows us to map along the entire commissure of the mitral valve, looking for the location of the jet. And it also allows us to hone down on the location of, for instance, prolapsed or flail segments. Now, here I mentioned biplane. That's a simultaneous display of two orthogonal views. Generally, this is the bicommissural view and the long axis together. Those two views are the workhorse for the entire procedure. So seeing those views on the screening echo with and without color flow Doppler is particularly important. For mitral valve area measurement, the transgastric basal short axis, or reconstruction from a 3D mitral valve on fast loop. Also from mitral valve area, a transthoracic measurement with a good view of the basal view is also fine. So, moving on. Oh, yeah. I just wanted to mention for the septum, we use the bicaval view and the four-chamber view. Next slide here. Okay, so 3D is particularly important because it allows us to confirm the location of pathology from our 2D loops. Also is particularly useful when examining any pathology near the commissure, and also for the presence of cleft-like indentations or clefts in the valve. So if there's leaking from such an area, your ability to clip and treat that regurgitant jet will be limited. All right. So I'm talking about concerning features that could preclude doing a successful procedure. So since the Everest trial, inclusion and exclusion criteria were published in 2010, and those have since been expanded. So we talk about now, we grade the procedures from easy, medium, or hard, or green, yellow, red. So when we look at anatomic features, if we want to do an easy case, that would be more central pathology. It's a less cord-rich zone. We're looking that we wouldn't see any calcium on the leaflets, that the mitral valve area is adequate, the gradients are not elevated, and that we have a flail gap, so that's the distance between the leaflet tips at the zone of least coaptation, of less than 10 millimeters, and the width of any flail segment will be less than 15 millimeters. We're also looking for a large atrium, so there's plenty of room to maneuver. Patients should have good imaging and no intraatrial septal pathology. So medium, that's more lateral or medial pathology, multiple jets, larger flail gaps, widths, some calcium, but not in our grasping zone, potentially difficult imaging or some septal pathology. And hard is things like clefts, thickened, immobile, rheumatic leaflets, short leaflet length, decreased mitral valve areas, less than 3, and LAA thrombus. So, oh, sorry. Now, technological advances have allowed us to push the limits of what can be done, and they've developed a longer and a wider clip with independent grasping of each arm. Also, we have multi-plane imaging in real time, which can allow us to display the bicommissural views in addition to the 3D view simultaneously to allow us to maneuver more quickly, and there's less switching between modalities. So let's go through. We're imagining we're at the procedure, and here I'd just like to acknowledge my echo partner, Dr. Ashley O'Brien, who is immensely helpful. We do these cases together. So thanks to him. So first, we need to cross the septum. Now the main action happens on the left side of the heart, but we need to really choose the right place to cross the septum so that we can maneuver the device and reach the valve. So there are 3 points of reference there. The most important aspect is that we need to cross in the fossa ovalis, the thinnest part here of the septum. If you do not, you can expect to develop pericardial effusion during the procedure. So our points of reference in the bicable view, we choose the midpoint here. In the short axis aortic valve, we want to be posterior, but still within the fossa. And then once we see tenting on these views, we double check that we have adequate septal height, so more than 4 centimeters, so that we can have adequate working distance to the valve. So next, we get the steerable guide catheter in, the clip delivery system, and we need to reach the landing zone. So what is the landing zone? Well, the landing zone is the area of the valve that we have identified with the maximal regurgitation and the particular pathology that we want to address. So as I said, we use the bicommissural view displayed along with the long axis. So this is the biplane imaging modality, to allow us to maneuver the clip down. So in the long axis view, you see the clip, it is open and you see both arms. Now at 90 degrees, you just see here the tip of the clip. So that allows us to see there's proper alignment. And then we also double check that the clip is orthogonally directed to the mitral valve commissure. We then go through the valve, double check our placement by undergaining on 3D, and then we close the clip slightly and retract and attempt to capture the leaflets here in the clip arms. Once we see that the leaflets have been trapped in the arms, we see less mobility, we can then try to close the clip. So, okay, so when we close the clip, We are looking for reduction in mitral regurgitation here. So we use color flow Doppler. We also go just in 2D plane to ensure that there's a good grasp of the leaflets without excess mobility, that each arm has trapped a leaflet fully. We also look for what's called a tissue bridge, that again, the clip is oriented perpendicularly to the valve commissure and you have an equal grasp on each side. Next, we look for other supportive Doppler criteria for MR reduction. So pulmonary venous waveforms are crucial in determining how well we've achieved that goal. If we look for Doppler waveforms that go from a systolic wave reversal to a normal pattern. We also check a valve gradient, looking for trying to rule out that we've created any mitral stenosis. So provided we're happy with all these things, we would then release the clip. We then reevaluate and determine, do we need another clip or can we complete the procedure? So once we've stopped clipping, we then remove the steerable guide catheter and we're left with an iatrogenic ASD, which we normally leave unless there's important right to left shunt. And this tends to heal somewhat spontaneously. All right. All right, so quantification of MR post repair, is it easy? No, not really. There's really not a great quantitative method, so we have to integrate various parameters together. So color flow Doppler characteristics of MR jets we would use, and usually there's multiple jets, and they are often eccentric. They may be combining, converging, so it can be very tough. So we also use hemodynamic criteria of raising blood pressure, and also increase in LVOT-VTI reflective of increased stroke volume. The left ventricular ejection fraction often drops, and we may see echo contrast in the left atrium. The pulmonary venous pulse wave Doppler is critical, as I mentioned, and other criteria like mitral valve inflow velocities can be helpful. So, oh yeah, there's been a lot of discussion recently about the value of 3D vena contracta. Here's one I've done on one of my patients, pre-clipping. It's tricky and it takes a while, so it's not practical, in the progress of the procedure, but it can be done. So I have some clinical cases, but I think we're kind of out of time from what I can tell. But I'll just briefly say about some pathologies that we have addressed. So P2 prolapse in an octogenarian here. So here's a guy with P2 prolapse that we were able to successfully clip with more normalization of the pulmonary venous waveforms. And here you can see the ventricle looks quite a bit, you've uncovered the dysfunction there when we clip the valve. Secondary MR also, we've done quite a few of these cases. So here's a patient with ischemic cardiomyopathy, a number of different problems with severe secondary MR. And with him, we were able, I'll just quickly go to that, to get a successful MR reduction. And there was also a case we did for P1 prolapse. But what I'm going to do is I'm going to come out and go to the end here because we're pretty much out of time. So further clinical applications. So when we meet with our working groups, we see applications to systolic anterior motion, the anterior mitral valve leaflet, as in hypertrophic cardiomyopathy and valve interventions. In shock, acute MR from papillary muscle rupture, and also tricuspid regurgitation is increasingly being addressed with this technique. So conclusions and questions. So, TE is used for screening, guiding, and evaluating results It's very echo intensive. Biplane and 3D imaging is instrumental to success, and the technological advances have really led to a quickly changing landscape. I'd like to thank some of the members of the team that are that have come on since we started. Ashley O'Brien, Brent McGrath, and most recently Mike Racco. Um, and there's some references. Thank you.
All right, Jennifer, thank you very much. So maybe I'll ask the first question before I see if people are putting their hands up. Is what do you sort of your best advice to sort of get the biplane and the 3D sort of comfortable in doing those kinds of images? Like you really highlighted quite nicely
Yeah,
how it allows you to really
absolutely.
truly in the same frame be able to tell, is that jet central, a little bit to the side, not, you know, that kind of stuff.
Yep. So I'm just going to bring up the slide. So the landmarks for the BICOM view. So basically, here it's zoomed out a bit, but when you zoom out, you want to see the both papillary muscle heads here. You look for the left atrial appendage and the coronary sinus. What you want to see is A2, which is a little bit of a bump here going down so that you see a gap in the middle, and then you see to the lateral side P1 and P3. You get that centrally, and then you turn the probe clockwise and counterclockwise to scan a little bit, because jets through the center fine you may see, but also jets may be a bit more eccentric, so you want to capture them as well.
And in terms of the 3D reconstruction, what would be sort of your best advice to, I mean, you had beautiful views
Yep.
there. You know,
So
sometimes people have a hard time, they'll give us only half the valve, you know, those kinds of, yeah.
sorry. Yeah. So basically, it's actually easier than it looks. So what you do is you get a nice 2D view. Usually I start from a BICOM view of the mitral valve and use this 3D zoom function. So you select your window there to include the entire valve, and then you just press 3D zoom and it automatically does it. And then you orient it to the surgeon's view just by using the trackball to manipulate it. And then when you do 3D reconstructions, they're now actually on cart. Basically, whenever you activate 3D, you can press multiplanar reconstruction mode. And right there on cart in real time, you can manipulate the cursors to achieve the planes that you want.
Okay. Yeah, it's very helpful for us, certainly when we're thinking about the valve, looking in this way where you see the anterior and the posterior leaflet in real life and see the leaflet coming at you or where the defect might be. And even from a mitral clip or mitral valve repair point of view, it gives me an idea of, do I want to attach cords to the medial or the lateral papillary muscle? So big difference. So any questions from the audience or things that, you know, thoughts you have? I know we mentioned the mitral valve area. It's one of those that, you know, it sounds silly, but if you think about it, the valve area we're looking for, 4 centimeters squared, is because we know we're going to make it smaller with one clip, but it also gives us an idea if it's going to be a 2-clip case or not. So if we have a big defect with lots of issues and a small area, we really need to think of a strategy that will allow us a 1-clip strategy versus a very large area where we know that we have the luxury of putting potentially 2 clips. So that makes a difference. And you also mentioned the leaflet length. The reality of the clip is the smallest clip we have is 9 millimeter grasp. So we need at least 9 millimeter of decent leaflet from, let's say there was calcium close to the annulus, is we need a little bit of distance. You see here, the arm lengths are 9 and 12 millimeter as the largest. So these are small measurements, but these are things that we all spend the time looking at the echo and looking at those measurements to see, like, is there enough posterior leaflet there? Is there 9 millimeters of length for me to work with? If there isn't, then you can't consider that patient for mitral clip. So these are all tidbits of information that are helpful. I hope anyways, from my point of view, Jennifer, there's a question from Amy. Do you want to go ahead, Amy?
Yeah, just a quick question. What would be your preferred view to accurately measure leaflet length? Would it be the long axis?
Okay. So, whoops. So first of all, it depends. You want to go to your, you want to locate pathology that you want to clip. So it's usually where the jet is largest. So, you need to examine that area. So often, you know, if you're in the A2P2 region, yes, the long axis view will be good for that. But sometimes also what I do is I'll find the pathology on the 3D and I'll just break down that view and measure that leaflet length. So yeah.
Yeah, because the grasp that we're going to do is really most often in the place we think the defect or the amount of regurgitation is the worst. So that's quite right. And that's where that spot is important to.
Yeah. So just further on that. So if your pathology is, for instance, in P1, you would have to try and find the best view that's sort of perpendicular to the plane of the commissure at that level, which won't necessarily be a long axis view.
Okay, thank you.
I don't know, Jen, you mentioned sort of briefly the sort of chordae rich area. That may be something that people might not fully understand what you meant by that.
Mm-hmm.
If you want to just elaborate for a second.
Okay, so I mean, as a surgeon, you could elaborate even better, but basically, the chordae, they issue from the papillary muscles from each side. Each leaflet, anterior and posterior, gets chordae from both papillary muscles. So the papillary muscles send their chordae. There's primary and secondary. And the area most central in the valve at A2P2 is an area where the density of chords is less. As you approach the commissures, it's a lot more chord rich in that zone. So that's why on the green, yellow, red table, the A2P2 pathology is deemed easy.
Yes, no, absolutely right. And I think when it becomes chordae rich, it often is thin, small chordae that are easier to tear or rip as you do potentially multiple grasp or move. So you can actually make the valve worse rather than help.
Yeah, so here we had in this P1 case, for instance, this was extremely difficult. We spent about 8 hours working on this case. I almost had chest pain considering potential esophageal injury. And let me see. Oops, I probably stopped the presentation. How do I? Yeah, so here we were able to place 2 clips, but they ended up being one on this side and one on this side, kind of in a chevron pattern. But what happened is we did damage some cords, and early on in the procedure made the regurgitation even worse. We were able to rescue it with 2 clips, but it was difficult, it was frustrating, and you could see chordal matter, free chordal matter at the end of the case.
Yeah. So with that, Jennifer, thank you very much for rounds. Unless there's any other questions, I don't see any on the other than great talk from Craig. Thank you, Craig. I agree, this was fantastic. Thank you very
Thanks
much.
so much. Thank you very much. Thanks everyone for tuning in, and I just am grateful to be part of such a wonderful team.
Thank you.
Thank you.
Thank you. Have a good day.
Thanks.
Bye.